بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الرابعة في كلية الطب جامعة بغداد، أرحب بكم في المحاضرة الثانية بالأورام. أنا دكتور مازن جودي، أستاذ مادة الأمراض الباطنية والتخصص دقيق في علاج الأورام في كلية الطب جامعة بغداد. أرحب بكم هاي المحاضرة إن شاء الله، راح نقدمها تشمل كلام وعلاج حول الكولوريكتال كانسر اللي هو سرطان القولون كجزء أول، مبادئ أساسية في هذا المرض، وكذلك الجزء الثاني من المحاضرة حول سرطان الرئة. So let's start with the colorectal cancer. About the epidemiology of this cancer, globally nearly about 1,200,000 new colorectal cancer cases are believed to occur, which account for approximately 10% of all incident cancers, and it is the third most common cancer in men and second most common cancer in women, and considered to be the second cancer leading cause of death in men exactly rather than females, because breast cancer considered as the second most common cancer in death after the first leading cause of death regarding the cancer, which is the bronchogenic cancer. Now, regarding the geographical variation, colorectal cancer incidence and mortality rates are the greatest in developed Western nations, mainly sporadic without hereditary factor. And hereditary factors are present also. These include the FAP, which is familial adenomatous polyposis coli, and mainly also another one, which is hereditary non-polyposis colorectal cancer. Inherited mutations in the genes, which are DNA mismatch repair genes, may be more common among African Americans. Now, the etiology of colorectal cancer includes interaction of two main factors, which are the environmental factors in the presence of the genetic susceptibility. When there is genetic susceptibility and exposed to environmental factors, this will lead to the development of the colorectal cancer. Regarding the etiology also, the environmental factors which are important that increase the risk of colorectal cancer, mainly regarding to the diet habit of this patient. The high calorie diet, high red meat consumption, overcooked red meat, and high saturated fats, excess alcohol consumption, these may be related as environmental factors that will expose the person to the development of colorectal cancer. Also, other factors include the cigarette smoking, sedentary lifestyle, obesity, and diabetes. All these can increase the risk of colorectal cancer. While the high fiber diet, antioxidant vitamins, fresh fruit, vegetables, non-steroidal anti-inflammatory drugs, mainly aspirin, coffee, there is some trials and studies about the role of coffee in decreasing the level of the colorectal cancer. A high calcium diet, high magnesium and bisphosphonate like hyaluronic acid drug, all these can decrease the incidence of this type of cancer. We have to discuss the polyps because of its importance in the development of the colorectal cancer. The evolution of cancer is a multi-stage process. What is the multi-stage? That's meaning it's starting from simple thing, changes in the pathological features, and then step by step will develop the cancer. Through the mucosal cell hyperplasia first, then adenoma formation, growth dysplasia, and then malignant transformation and invasive cancer. So there are different steps till reaching the invasive adenocarcinoma of the colon. Types of polyps histologically are classified as non-neoplastic polyps and neoplastic polyps. The non-neoplastic polyps, there is no malignant potential. That's to say the patient has this polyps, but there is no high risk of development of malignancy, and this includes the hyperplastic polyps, mucus retention polyps, hamartomatous polyps, which is called the juvenile polyps, lymphoid aggregates, and inflammatory polyps. While the neoplastic polyps, these are adenomatous polyps. These polyps can lead to the development of the malignancy later on. They have malignant potential and are classified according to the WHO system as tubular or mixed histology or villus. So the neoplastic polyps, there are three types histologically, either tubular villus or mixed, what is called the tubular villus. The tubular characterized microscopically by networks of complex of branching glands. This characterized by tubules, the glands like tubules. The mixed histology, they are villi in addition to the presence of the tubules. Okay, while the villus mainly composed of villus compartment, and this villi, the villus, carries high risk of development of malignancy. Generally speaking, the polyps that are larger than 1 cm in diameter, those with high-grade dysplasia, and those with predominantly villus histology are associated with higher risk of colon cancer, and this condition the patient needs screen for the development of the malignancy. The other types of polyps, which are called inflammatory bowel, away from the polyps, there is another cause for the development of the malignancy, which are the inflammatory bowel disease, which include mainly the ulcerative colitis as etiological factor. Also, Crohn's disease carries low risk of development of malignancy. Regarding the ulcerative colitis is a clear risk factor for colon cancer. About 1% of colorectal cancer patients have history of chronic ulcerative colitis. And the risk for the development of cancer in these patients varies inversely with the age of the onset of the colitis and directly with the extent of the colon cancer involvement and duration of the active disease. So the patient will develop ulcerative colitis in younger age, he has a more chance of development of malignancy, and also the extent of the involvement of the chronic mucosa and duration of the active disease. All these play a role in the development of malignancy in patients with ulcerative colitis. The other type of inflammatory bowel disease, which is the Crohn's disease, as the patient with colorectal Crohn's disease are at increased risk of colorectal cancer, but the risk is less than that of ulcerative colitis. The risk is increased about 1.5 to 2 times in condition of inflammatory bowel disease, Crohn's disease. Now, what's about the FAB? FAB is familial adenomatous polyposis. This is an hereditary disease. It constitutes about 1% of all colorectal cancer incidence, and the hallmark features include hundreds to thousands of colonic polyps, as it is seen in this figure. In this picture, there are hundreds to thousands polyps in patients in their teens to 30s, and if the colon is not surgically removed, 100 of the patient will progress. So it carries a high risk of development of malignancy, since 100 of the patient of the colorectal of the familial adenomatous polyposis coli will develop later on the colon cancer. FAB it is an autosomal dominant disorder with nearly 100% penetrance. Colorectal polyps begin to develop on average about the age of 16 years. So the polyps will increase and it appear clear in the age of 16 years. The mean age of colorectal cancer is about 39 years. Lifetime risk of colorectal cancer is about 70%, with an average age at onset of 50s. So, starting from the age of 39, there will be high risk of development of malignancy in this group of people, and increase the incidence. About 70% of them will develop at the age of 50s, but the incidence of colorectal cancer in this type of hereditary disease is 100% with penetrance. The FAB not only include the polyps in the colon, but also include extracholic manifestation, include benign condition like congenital hypertrophy of the retinal pigment epithelium, mandibular osteomas, which is benign tumors of the bone, supernumerary teeth, epidermal cysts, adrenal cortical adenomas, and desmoid tumors. These could be associated with the presence of the familial adenomatous polyposis, and usually some of them seen with the patient of malignancy and history of FAB. The malignant conditions also away from the adenocarcinoma of the colon, the patient may develop thyroid malignancy. Also, gastric small intestinal polyp with 5 to 10% risk of duodenal or ambulatory adenocarcinoma, that's to say small intestinal malignancy, not only colon cancer. And also some of the patients have brain tumors in addition to the CA colon. The brain tumors may be of two types, either glioblastoma multiforme or medulloblastoma, and the particular association of brain tumor in the colon called Tearcoat Syndrome. So Tearcoat Syndrome includes the combination of the colon cancer with the brain tumors in patients with FAP. The colonic polyps in Tearcoat Syndrome are fewer and larger than the classic FAP. Also, it is found that the polyps in patients with Tearcoat syndrome, they are smaller in number, they are fewer in number, but they are larger in size than the classic FAP. The other hereditary factor that lead to the development of the colon cancer and higher percentage than FAP, it is called hereditary non-polyposis colorectal cancer. In HNPCC, which is hereditary colorectal cancer, it's found about 3% of all colorectal. And it is also autosomal dominant disease with about 80% of penetrance. Now, genetic and biochemical approach led to the discovery of involvement of human DNA mismatch repair genes. So the problem here, there is in the mismatch repair genes in the patient with this hereditary factor. The saline features include up to 100 colonic polyps. So the patient has polyps, but the number of polyps less than that of FAP. And hence, the term is called non-polyposis. Okay? Preferentially, albeit not exclusively, in the right or proximal colon. So the usual site of the presence of the polyps and colorectal cancer is in the right side of the colon, which is the ascending part of the colon. There is an accelerated rate of progression of colorectal cancer, and polyps with mean age of onset is about 43 years. This is designed as hereditary non-polyposis colorectal cancer type 1. There are two types of HNPCC, which is type 1 and type 2. Type 2 is the Lynch syndrome. Is distinguished by extracolonic tumors that originate in the stomach, small bowel, bile duct, renal pelvis, ureter, bladder, uterus, ovary, skin, and perhaps in the pancreas. Actually, the most important visible in the patient, usually female with colon cancer and uterine cancer in the Lynch 2 syndrome, but also other organs like the stomach and bowel, small bowel or biliary tract tumors, or patient could develop ovarian and perhaps pancreatic tumor. A variant of hereditary colorectal cancer is designated as immutatory syndrome. This immutatory syndrome, the patient develop both colon cancer with skin tumor, and the patient has hereditary non-polyposis colorectal cancer. Now, how can we diagnose patient with colorectal cancer? The diagnosis of this cancer after the clinical suspicion of colorectal cancer, several diagnostic and evaluation steps should be taken. So the patient may suffer from infrequent bowel motion or bleeding per rectum, in addition to the fatigue and the features of anemia may present with features of anemia, may present with features of loss of appetite and weight loss. Now, after taking history from the patient and the clinical examination, we'll start with the final diagnosis through the investigation. The most important and cornerstone in the investigation is biopsy taking. Biopsy confirmation of malignancy via colonoscopy, and general evaluation that includes complete physical examination, of course, with digital rectal examination, CBC, at complete blood count, liver function test, and chest imaging to detect presence of any metastasis, of course. And also Carcinogenic antigen, which is important tumor marker that is serological level. When it is elevated, gives an idea about the suspicion of malignancy. A preoperative CEA can be useful as a prognostic factor and in determining the primary tumor and is associated with CA elevation. So it is should be recorded as baseline and then follow-up of the patient after treatment as the response of the surgery and chemotherapy. The preoperative CA elevation implies that CA may aid in early identification of metastasis because of metastatic tumor cells are more likely to result in CA elevation in these circumstances. That's to say, when we find the patient on follow-up elevated level of this tumor marker, we have to look for any site of recurrence or metastasis. The other important tests, of course, are the imaging tests, which include the CT MRI with contrast media on the chest, abdomen, and pelvis that may identify any small metastasis in the lung, liver, or intraperitoneal metastasis. Endoscopy, also what is called CT colonography, is indicated to assess the entire colon mucosa because about 3% of patients have synchronous colorectal cancers and a larger percentage have additional pre-malignant polyps. So after we take biopsy from the patient, we have to examine all the chronic mucosa for presence of other primary tumor away from the site that is diagnosed. EUS is the endoscopic ultrasonography is significantly improved the preoperative assessment of the depth of the invasion of large bowel tumor, especially the rectal tumor. EUS important in condition of the rectal tumors rather than colon by using of ultrasound method. A PET scan also is of an increasing utility to help distinguish the anatomic lesions of unclear origin are malignant or benign. Such a scan also useful to determine if localized or metastatic disease is potentially resectable. And PET scan will give the patient specific material that is 5-fluorodeoxyglucose, which is taken by the malignant cells and then seen by specific method in nuclear medicine, and the cells that take this substance are highly suspicious to be malignant cells. Of course, there are false positive and false negative results, but usually is effective in the determination of the metastasis of the cancer, whether being CA colon or other types of malignancy, with the exclusion of certain types of malignancy. So PET scan also play a role in the workup and diagnosis of the colorectal cancers. Like other cancers, multidisciplinary team is very important for any cancer. Regarding the guideline of oncology, MDT, which is called multidisciplinary team, is important to determine the appropriate treatment for this cancer, whether surgery, whether giving treatment before surgery, what is called neoadjuvant treatment, and then surgery. The surgery usually include the hemicolectomy, that removal of part of the colon involved by this malignancy. And after we remove the malignancy, we find the stage and the treatment accordingly. Now the polyps and stage 1 colon cancer, in which there is T1M0M0 or T2M0M0, here meaning there is the malignancy involved the mucosa or the muscular layer without involvement of the lymph node or away from the area of malignancy. So it is localized early stage. In this condition, there is no need for giving the patient treatment adjuvant chemotherapy, since there are the risk of recurrence of malignancy in this condition is very low, and the patient usually have 5-year survival without chemotherapy, about 95%. It is found also if there is recurrence in patient diagnosed as stage 1 malignancy of colorectal cancer, most likely to be wrong diagnosis from the start. The patient is stage 2 or stage 3 and diagnosed wrongly as being stage 1. Now again, the stage 2 and the stage 3 malignancies here, stage 2 has specific indications for adjuvant chemotherapy. Not every patient with a stage 2 is indicated for chemotherapy, such the patient that have high risk features. And these high risk features include the perineural invasion, presence of perineural invasion or lymphovascular invasion, or lymph node that are inadequate for the diagnosis, less than 12 lymph nodes removed with the surgery, or the patient has T4 stage, that including the involvement whole layer of the colon or rectum and the perirectal or pericolonic region. This is called T4 stage. Positive resection margin, the malignancy is removed, but the margin of this surgical specimen still has malignancy. That's to say, the patient has also malignant cells still in his body. And also, if the patient presented with obstruction of features of intestinal obstruction, or presented with perforation and bleeding, severe bleeding, in these condition, the patient with stage 2, even there is no lymph node involvement, still he is indicated for the adjuvant chemotherapy. While if the patient has stage 2 by histopathology and there is no risk factor, also there is no indication. In stage 2 colon cancer, need treatment, only treatment, the chemotherapy is 5-fluorouracil, which could be given as an infusion or oral tablet, which is called capecitabine, oral 5-FU. In stage 3 cancers, in this condition there is lymph node involvement. Here the patient needs adjuvant chemotherapy, including the 5-fluorouracil, in addition to the other drug called oxaliplatin. This is called Volfox, or protocol called Zelox, and this given for 6 months. Okay. Now, the rectal cancer has specific features. The specific feature of rectal cancer being specific anatomical features. He has high risk of recurrence and also may need neoadjuvant chemoradiation. That's to say, giving the patient before surgery chemotherapy with radiation for downstaging of the malignancy, decrease the stage of the tumor, and also a preservation of the anal sphincter, because the rectum upfront surgery without giving neoadjuvant chemotherapy, sometimes we have to sacrifice the anal sphincter and the patient end with permanent colostomy. In stage 4 disease, meaning stage 4 disease that the patient has metastasis away from the origin of the malignancy, may involve other viscera like the liver and other organs, lung, and so. If the patient has oligometastasis from the start, that's to say only involving single lesion seen by the imaging test and by PET scan, in this condition the patient will undergo hemicolectomy for the primary origin of malignancy, together with metastatectomy, that's to say removal of the site of metastasis. While if the patient has many areas involvement by the malignancy, here there is no role of metastatectomy and the patient need to receive palliative treatment. The palliative treatment is a specific type of chemotherapy given together with a specific monoclonal antibody, which is targeted therapy called bevacizumab, given into the patient, and follow-up of the patient every 3 months. If the patient has downstaging and is accessible for surgery, we do surgery. Otherwise, the patient will be kept on chemotherapy and biologic drug. Also, if the patient has progression, there is second line, third line, there is immunotherapy, etc. So there are many lines of treatment as palliative treatment for patients with colorectal cancer in stage 4 disease. The other part in this lecture is regarding the bronchogenic cancer. Bronchogenic cancer is important. I select actually these 4 types of cancer. In the first lecture, I talked about the breast and ovary, and now I talk about the colorectal cancer and bronchogenic cancer, as they are common malignancies in our country. Bronchogenic cancer, lung cancer, is the most common cause of cancer death worldwide. The most common cause, leading cause of death being cancer in the whole world. It accounts about 15% of all cancer diagnoses and responsible for 28% of all cancer deaths. The incidence rate in men appear to be falling or at least stabilizing in all regions. In contrast, incidence rate in women appear to be increasing in most regions. Because of decreasing smoking habit generally in the world, decrease the incidence, and especially in men. But unfortunately, many females use now smoking and pipe smoking, other cigarette, and they develop and increase the risk in this gender of human being. So etiology mainly is smoking. Smoking is the most common cause and responsible for about 85% of all cases. More than 50% of carcinogen in tobacco have been identified, including the N-nitrosamine, polycyclic aromatic hydrocarbons, may be metabolically activated to become carcinogen. So there are multiple carcinogenic substances in this cigarette. Nicotine being the primary determinant of addiction. So nicotine is not carcinogenic substance, but it is the primary determinant of addiction. And the tar being the residue left when nicotine and water are removed from the tobacco smoke. Also, occupational or environmental exposure being 10% of lung cancer. 10% are related to the occupational exposure, including the asbestos, beryllium, arsenic, chromium, radon. COPD, that is chronic obstructive pulmonary disease, also indicated as etiological factor. Idiopathic pulmonary fibrosis, high dose radiation. Also, radiation is an etiological factor for bronchogenic cancer. The diet, as deficient in vitamin A and C and beta carotene intake, have been associated with an increased risk of this type of cancer. And there is also, of course, genetic predisposition, as estimated 300,000 lung cancer deaths occur in non-smoker annually in world. In many of these, no risk or exposure can be identified, so genetic and epigenetic DNA changes contribute to development of the malignancy. Family history of lung cancer is a predictor of an increased risk. So the main etiological factor for the development of bronchogenic cancer is the smoking, but also there are other factors away from smoking. For example, adenocarcinoma of the lung, it is a specific important type, and this increasing incidence in female that they are non-smokers at all, but there is increasing especially in the oriental countries and in our country also. So there are multiple factors in the development of the bronchogenic cancer. Now, the types of lung cancer, there are two main types of bronchogenic carcinoma according to the histology of the malignancy. This is what's called non-small cell lung cancer and the small cell lung cancer. The non-small cell lung cancer, the malignant cells are large, and this also group divide into subtypes that are the squamous cell carcinoma, adenocarcinoma, and fully differentiated large cell carcinoma. This classification, all of this classification is dependent on the histopathologic features. But why we classify the non-small? Because the biologic behavior, the prognosis, the treatment also, all these different depending on the subtype of the malignancy. Other rare types away from these two types are what is called neuroendocrine tumors, also include the carcinoid and atypical carcinoid, as typical or atypical carcinoid, and also there is another group called large cell neuroendocrine tumor of the lung. How the patient will present to the doctor? Usually he suffers from the cough, increased production of sputum, hemoptysis also, and shortness of breath. And the patient may suffer also from fatigue, weight loss, anorexia, and also low-grade fever. The patient may develop rarely chest pain or hemoptysis, hoarseness of the voice, bone pain, pleural effusion, and infrequent presentation with complication of the mass. Patient when develop mass, he will develop these features above feature, but sometimes he neglect himself and present with features of complication like severe vena cava obstruction. The patient will present with severe shortness of breath and prominent vessels in the neck and the upper chest, and also it is an urgent condition. Also, the patient may develop with pericardial tamponade as complication with pericardial effusion and tamponade, and other perineoplastic features like the hypercalcemia in squamous cell carcinoma, or specific neuroendocrine features in small cell lung cancer like hyponatremia or other features. And sometimes the patient presented with an increased intracranial pressure, features of headache, vomiting, and signs of the brain metastasis. Now, how can we diagnose patients with bronchogenic cancer? the patient with a strong clinical suspicion based on the risk factors, radiological appearance. Many techniques are available for tissue diagnosis. So, in the diagnosis of malignancy, whether it is in the lung or other organ in the body, we have to take biopsy. The biopsy could be for histopathology or could be for the cytology. For example, sputum cytology, bronchoscopy with biopsy and transbronchial needle aspiration, image-guided transthoracic needle core biopsy or fine needle aspiration, thoracocentesis, mediastinoscopy and taking biopsy from the mediastinal lymph node, video-assisted thoracic surgery and open surgical biopsies. All these could be taken as a source for diagnosis of bronchogenic cancer. Now, before the starting treatment, we have to do evaluation for the patient. Evaluation of the mediastinal lymph node is the key step in further staging, because the drainage of this malignancy could be in the mediastinal lymph node. So we have to do mediastinoscopy and sometimes take biopsy. FDG PET scan, as I said, is an important step in the diagnosis of metastasis. Mediastinoscopy is the gold standard for evaluating the mediastinal lymph node. It's appropriate for patients with T2 or T3, even PET CT scan was negative. So the patient, when diagnosed by biopsy being T2 or T3 here, need mediastinoscopy because high suspicion of mediastinal lymph node involvement that could be not seen by the PET CT scan. Bronchoscopy is important, of course, to take biopsy or bronchial wash or bronchial brush from the mass. CT scan of the chest abdomen to detect metastasis. Brain MRI and spinal MRI sometimes is important, especially in symptomatic patients. Preoperative evaluation by spirometry for the pulmonary function test is also important before starting the chemotherapy or radiation. Bone scan when suspicion of bone metastasis. Okay. Now, what is the proper treatment for patients with bronchogenic cancer? Treatment is different according to the type of bronchogenic cancer. That's to say whether the patient has non-small cell lung cancer or has small cell lung cancer. Surgery is indicated for early stage bronchogenic cancer to be followed by adjuvant chemoradiation. If the patient presented with a bronchogenic mass and features of bronchogenic cancer and diagnosed and is accessible the mass for surgery, surgery has to be done. Inoperable bronchogenic cancer is indicated for palliative chemoradiation. In condition we cannot remove surgically the mass, then there is a role of chemoradiation with the choice of the chemotherapy. Depends on the type of lung cancer. For example, combination of etoposide and platinum for small cell lung cancer, while the use of Imatrix for the adenocarcinoma. Now, targeted therapy is indicated for metastatic lung cancer. For example, erlotinib is indicated for metastatic adenocarcinoma. The targeted therapy has the property of acting exactly on the malignant cells with less side effects than the chemotherapy. For example, the tyrosine kinase inhibitor erlotinib, which is used here for the metastatic adenocarcinoma of the lung. Okay, thank you.